So those were the complaints. So her vision was 660 in both the eyes, and near vision was N18. The rest of the ocular examination, as in cover test, ocular motility was normal. She was a high myope in both the eyes. Okay, and on anterior segment examination, she had nuclear cataract. But once we neutralize the refraction, as in, see, normally also high hyperopes and high myopes have dull glow. But once we had neutralized that refractive error, she had a good glow, as in the glow wasn't too bad despite having the cataract. And the dilated fundus examination in the right eye showed a macular scar in the right eye, and in the left eye there was foveal thinning. So we just gave her glasses and we planned to observe this girl. So she came back to us again in October 22 when the vision in the left eye had dropped to 2 meters. So we thought probably this cataract has advanced and that would be the reason that her vision has dropped, and we would probably have to plan cataract surgery for her, since we thought that initially there was cataract but we did not do. But to our surprise, what we found is a giant retinal detachment in the left eye. So of course, this had to be operated. The child underwent lensectomy, vitrectomy, and the whole retinal procedure, following which the retina was attached. It is attached for over a year now, because this was last October when she was operated for the retinal detachment. Now, because the oil has emulsified and it has come in AC, silicone oil removal has been planned. But whether to implant an IOL or not is still a little questionable, because when we perform oil removal, there are chances that the child may again develop redetachment. Hence, we are probably keeping it on hold, IOL implantation for now. So now coming to the second second case. So these two are siblings, okay? So the boy has also similar clinical presentation. He also came for a routine checkup, similar complaints. The vision was also similar. He was again high myope. But for him, I wouldn't say that the glow was too good. I mean, the glow was not so good, but still, since this was the first time, we just thought that we would give him a trial of glasses, since again they were high myopes, and high myopes are more prone to retinal detachment. So we gave him glasses, and the child was again on observation. Since both the siblings had similar presentation, high myopia and nuclear cataract, so we decided to just go ahead with some genetic screening in case, because there was no family history of cataract in both the in their family. At least the family denied that. At least the part of the family who came, we examined them all and none of them had cataract. So we went ahead with genetic screening to find out if there is any systemic condition which we probably would be missing in this case. But we could not arrive at a conclusive diagnosis. So this is the child who came again after later. The glow had become really dull, and now we have no other choice but to go ahead and do the cataract surgery. See, when we are unable to see inside, the child is also equally unable to see outside. So that is when we probably think that yes, surgery needs to be done. But here we have a fear in our mind, because there is high myope. The child is already pediatric cataract. The child has a high myopia, so they are prone for retinal detachment, especially when the child has developed, the sibling has developed retinal detachment. Even, I mean, more are the chances that the child may develop. So the doubt is still there in our mind, but still we have posted this child this upcoming week for surgery. So when we take into account of the pediatric cataract, after adult cataract, pediatric cataract is the most common cause of blindness, because it adds to the number of blind years. Because the child, I mean, if we take into account, say 70-year-old person or a 7-year-old child, the number of blind years which a child faces is much, much more. And the disability adjusted life year which a child faces because of cataract, it is much more. And it is an easily preventable condition. So we have to take this into seriously and treat it well. So coming to the morphology of the cataract, now depending upon the position of the cataract, like whether it is anterior or posterior or embryonic fetal nuclei, various morphology of cataracts are present. So usually this anterior are not visually what do we say? They are not visually handy. They don't cause much of a visual handicap. But the posterior ones, the central, the lamellar, these are the ones who which result in more visual disability. So these needs to usually undergo surgery. So anterior polar are sometimes associated with Alport syndrome, anterior segment dysgenesis. Posterior ones are associated with posterior, the remnants of Clockett's canal. So that those may be association of the posterior segment pathology. So this focal, sutural, coronary are usually harmless. They can be observed. We need not intervene these cataracts, but lamellar, this central pulverulent, nuclear, all these are visual disabling. So we have to operate these patients. So etiology in India is most common hereditary. A lot of times, I would say about 33% are because of hereditary reasons. Sporadic cases may also occur. In India, intrauterine infections are rampant, especially rubella and rubella, the toxoplasmosis, cytomegalovirus. All these infections are very common. When we ask for blood investigations, these infections are very common in cases of congenital cataract. We are not talking about developmental cataract. Congenital cataracts are transmitted from the mother to the child. So these are antenatal infections. So a thorough history taking is important here. Metabolic conditions like diabetic cataract, then galactosemia, mucopolysaccharidosis, such conditions are also very common. And in India, trauma is also very, very, very common. So we see a lot of traumatic cataracts too. So when if we start with medicine, first we have to take history, detailed history from the patients and the parents. I mean, so since when has the white reflex started? That is very important. The onset of white reflex. A lot of times parents don't notice it. They are not sure. So associated squinting and shaking of eyes, these tell us, these all will be like telltale signs since when this cataract has been present. Like in case of unilateral cataract, if squinting is present, we understand that this is not very recent in onset. This probably is quite old. And in case of shaking of eyes, in cases of bilateral cataract, that's also common. So we have to ask the mother about antenatal infections, whether she had any fever or any other infection during the pregnancy time. Family history is very important. When the family comes to us, we should shine light and shine torch in front of, or probably do a detailed slit lamp examination at least. A lot of times we see when both the siblings have cataract and we are wondering what is the reason, why do they have cataract? And when we shine torch in their eyes, we find out, yeah, family has, but probably they are not able to reveal it a lot of times, especially mothers. So we should do a thorough family history examination, or at least ask for history. History of consanguinity. Consanguineous marriages are very common in India, especially in South, in some particular communities, it is very common. And this results in cataract in children, and they are the ones who suffer. And when we see a child, we just don't look at the eyes. We look at the child as an overall, whether there are any associated systemic conditions, any metabolic conditions, any other developmental anomaly which is associated with the cataract. So all that also needs to be looked into. When we come to the ocular examination, we have to look at fixation preference. Does the child just wants to look with one eye, or is he seeing equally with both the eyes? If it is unilateral, then definitely there is going to be a fixation preference. But in cases of bilateral, if the density of cataract is different in both the eyes, then the cataract, we have to address the eye, which is probably more severe or more dense. Age-appropriate vision testing is necessary, like for younger children, pre-verbal children. Didn't get.
Yeah, please go ahead.
Okay, so we need to look at the vision testing. See, for pre-verbal children, we usually go by central study and maintained way of examination. There are preferential looking tests, but practically it may not be available always. So we can, whether the fixation is central, whether child is fixating following light, those things needs to be looked at. Whether the fixation is steady, whether there is any nystagmus or not, whether there is any squint or not, those things need to be looked at. And while we are evaluating the anterior segment, the morphology of the cataract is important, as in how dense is the cataract. A lot of times these membranous cataracts are very dense in the center, but the periphery is relatively clearer. So it helps us, during planning of the surgery also, it changes our approach. So that is also important. So also in cases of congenital cataract, watering is very common in neonates. So if watering is present, that means the child is having a risk of infection. So we have to advise lacrimal massage before we go in and do any intraoperative procedure. So any intraocular procedure. So we have to advise massage. Say, for example, if the child comes at 1 month's age and there is watering, we anyways are not going to take up the child immediately. So proper lacrimal criclar massage, if at all it is advised, then watering subsides, and then we kind of cut down on one surgery which is needed, and we just do go ahead with cataract surgery later. But with nasolacrimal duct obstruction in place and we go ahead with surgery, that is not okay. So we have to rule that also out. Pupillary evaluation a lot of time is important, because if in cases of total cataract where fundus is not visible, it tells us about the condition of the posterior segment. So a thorough pupillary evaluation is necessary. Strabismus, nystagmus, like how I mentioned before, that is necessary. Fundus has to be seen. Without seeing a fundus, we cannot post a child for surgery. In case if the fundus is not visible, we have to do a B scan to make sure that there is nothing abnormal in the fundus. Yeah, so once we are sure that it is cataract, we have to rule out all the other pathologies, any other corneal abnormality, any basically other causes of leukocoria. Those needs to be ruled out, like retinal detachment, coats, retinoblastoma. So all that is very common in the pediatric age group, especially in cases of unilateral cataract. So that needs to be ruled out. We have to do that with the help of B-scan. If necessary, MRI or further investigations in case we are suspecting of retinoblastoma, then those needs to be done. A-scan has to be done. With the A-scan, as in, because a lot of time the child may not cooperate. So intraoperative A-scan is necessary. Sometimes we may not have a library of lenses. So in case we don't have that, we have to do an A-scan before and then schedule later for the surgery. So that is also necessary. Handheld keratometers are necessary. Not every time we may have access to it. So in those cases, standard keratometry, standard K can be taken into account, say 43 or 44 diopters, and then we can do IOL calculations sometimes based on that as well if we don't have access to handheld keratometers. Investigations, if we plan to take up a child for surgery, so if there is a family history, then these investigations are not necessary. But in cases of congenital cataract, if there is no family history, then we have to do these basic tests, basically torch. We have to look at urine reducing sugars to rule out any metabolic conditions, syphilis, then serum calcium, phosphorus, glucose, galactokinase, and 2D echo is basically to have a safe anesthesia. So these investigations needs to be done. Once we decide that we have to operate this child, I mean, there has to be a reason when we take up a child for surgery. The vision should be less. There is decreased contrast sensitivity. The glare is there is increased glare. If the cataract is significant, if it is more than 3 millimeter, if it is located in the center, or if it is located in the posterior where the visual axis is getting hampered. Associated strabismus, nystagmus, those are the investigation in those are the conditions where we will take up the child for surgery. So when we think that the cataract is not significant, where the cataract is less than 3 millimeters, say in cases of anterior subcapsular opacity or anterior polar cataract, or a partially absorbed partial cataract which is of visual axis, we may choose to just give say a dilating drops if it is partially obscuring the visual axis. If needed, then glasses may be prescribed, or depending on the, say if it is unilateral, then patching may also be prescribed. And when we take up the child for surgery, a thorough evaluation is necessary, because we may not have a chance again to see the child as, I mean, the child is not going to cooperate outside the operation theater. So when we have the child under anesthesia, a thorough examination is necessary. Anticipating that the child may develop glaucoma later, we should do pachymetry, corneal diameters, check intraocular pressure, agonioscopy. And in cases of total cataract, when we have removed the cataract, it would be a good idea to look into the fundus before we implant a lens, because what if there is a pathology there, then there is no role of putting an IOL. So intraoperative fundus also needs to be seen, because later we may not get a a look what we may have interop. Later, the child is not going to cooperate as well in the OPD. So once we take the child for surgery, technically it is a little tricky surgery. It is not like adult phacoemulsification. Pediatric cataract is not adult phaco. So anterior rhexis needs to be performed. So staining is a very good idea. Trypan blue, because the capsule is very elastic. If we inject trypan blue, the capsule becomes a little tense, and performing anterior rhexis is easier. We can perform with manually with the microrhexis forceps, or we can also do with the vitrectomy cutter. Technically with the forceps it is little challenging, but that is probably the best way to do it. So once we have done the anterior rhexis, we aspirate the lens, and the size of the anterior rhexis has to be bigger as compared to the posterior rhexis. And technically posterior rhexis is much more easier. The chances of anterior rhexis running off is much more, but somehow we have some some mind blocks with when we perform posterior rhexis, but it is not so difficult technically. And then we have to perform anterior vitrectomy, and then we implant the IOL in the back. We have to suture all the wounds, which can be done with an absorbable or a non-absorbable 10-0, either Vicryl or 10-0 nylon. Less than 2 years of age, usually we were a little skeptical whether to implant or not implant an IOL, but these guidelines have kind of changed when the the corneal dimensions are good, say 12 mm, or if there is no microcornea or microophthalmos, we can implant an IOL. It is not a total contraindication. Between 2 and 8 years of age, there is clear-cut guidelines that we can implant an IOL, provided the corneal diameters are good. Corneal diameters are at least 12 mm. And in more than 8 years of age, if the child is cooperative, we may get away without doing a PPC or ANTWIT, because we expect the child would cooperate for capsulotomy. So that can be done as an OPD procedure later. So it is not mandatory for us to perform a PPC and ANTWIT. But in case of a developmental anomaly where we feel that the child may not cooperate, we can perform PPC and ANTWIT right away. These are some important conclusions from the IATS study. So less than 7 months of age, the consensus is preferably avoid an IOL, because those kids were more prone to glaucoma. So it is better to avoid IOL in those cases. And if we see a child with cataract on day 1, then we preferably wait. In cases of bilateral cataract, we preferably wait until 8 weeks, because the anesthesia is also becomes safe by then, and there are increased chances of glaucoma if we operate in first month of life. So because of these 2 reasons, we preferably wait until 8 weeks. In cases of unilateral cataract, to avoid amblyopia, we can pose these patients a little early at 6 weeks of age. So these were the guidelines given by the Han, where we plan under correction. So the idea here is, say, for example, the child is 2 years of age. In less than 2 years, the under correction was suggested about 20%, and between 2 and 8 years of age, the under correction is about 10%. What do we mean by under correction here? So the child is in a dynamic state. The eye is growing. So say if we target, say 2-year-old child, if we target, say plano, then as the child grows, the child is going to become a myope. So if we place, say 18 diopter lens instead of 22, say we were targeting 22, instead of 22, if we place 18, as the child keeps growing, so there would be about, say, +4 of hyperopia. So as the child grows, this +4 is eventually going to become 0 when the child attains emetropia. So that is the idea behind undercorrection. Hence, we undercorrect children. So NAD et al. Has given a formula. 7 minus whatever is the age, that is the target hypermetropia that we aim. Say, for example, if the child is 3-year-old, then 7 minus 3 is +4. So we target +4 of hyperopia. So that is the usual guideline that we follow, but this may change as a patient. And despite the best of attempts that we take for the surgery, the complications do occur. Glaucoma and retinal detachment is not uncommon. It is very common in kids. Visual axis opacification does occur. In case if just the posterior capsule is fibrosed, then we can get away by doing a yak capsulotomy. In case if it is much more than that, if it is dense, then we may have to go inside and do a membranectomy. It may be by an anterior approach or by a retinal approach. By a pars plana anterior vitrectomy may also be needed. Inflammation is common, especially in uveitic eyes and traumatic eyes. So that also needs to be addressed in case if at all it happens. Glasses would be needed, that we have to explain the parents clearly. Whether we put in a lens or we don't put in a lens, glasses are mandatory. Depending upon the whether it is a pseudophakic eye, it would be a thin glass, and if it is an aphakic child, it would be a thick glass. Contact lenses are described in all studies, but practically in our scenario, where the maximum incidence of cataract is in lower socioeconomic groups, it is very difficult to handle contact lenses. We are not sure if they would be able to maintain the hygiene with contact lenses. So it's better to go ahead with aphakic glasses. Children wear glasses very happily. It is not a difficult task to make them wear glasses. And we have to address amblyopia also. Otherwise, there is no point in taking the child undergo this procedure. If we have left the child aphakic with the primary surgery, then we need to implant IOL. So when should we be planning implantation of a secondary IOL? So usually not before 3 years of age for sure. 3, 4 is a good age where we can implant IOL, targeting about +3 or +4 of hyperopia. But before we implant an IOL, we have to make sure that there is no glaucoma, because since we would be implanting this lens in the sulcus most of the times, we have to make sure that there are no chances of glaucoma. The IOP and the retina should be all normal. Only then we can implant an IOL. Doing a surgical PI is a good idea again, because we are implanting the lens in sulcus. So coming to quiz time. I don't know if people are here to answer. Look at this photo here. What would be the management of this child? You all can unmute and answer if you can see. This is a child 1 month old. The parents had sent this photograph, and this is the photograph on Zoom. If you can make out, there is an opacity here, but there is a small clear area here.
Anyone can take?
Okay, I will only answer.
Could be
So,
ectopia lentis.
Yeah. No. Okay, ectopia lentis. This is 1 month old child. Will there be so much subluxation in 1 month old child? I'm not seen until today, I feel.
The sclera is also slightly bluish.
Yeah, the sclera looks slightly bluish, though it was not bluish. This was anterior subcapsular fibrosis. Basically, it was a membrane, but when we dilate, the child had a clear zone here. So we actually just gave her dilating drops, and the child is doing well. This was 1 month age. Today, this is the child. And thankfully, by just giving dilating drops and by patching the good eye, there was no significant refraction. So we made sure, we asked the parent that you have to see this clear zone always when you put the drops. So tropicamide was given as a treatment, and the child is doing well. She is reading 6/9 today with both the eyes. So we are very happy that without any surgical treatment. So the most important thing which I feel is when to not operate. That is very important to learn, especially in pediatric cataracts, because by doing a surgery, we are taking away the accommodation of the child, and accommodation is very important for a child because they have to study, they have to read all the time. So having to wear glasses is very difficult, because any sort of treatment becomes a burden on the child. So how much ever conservative we can be, that will help in the long run for a child. Coming to the second question, why do we do PPC and anterior vitrectomy? What is the reason for secondary membrane or visual axis opacification which happens? Why does it happen? From where does the cells migrate, and where do they go?
Mitotic cells from the equatorial region.
Yeah, they migrate and they go posteriorly, right? So that is the reason why the visual axis opacification occurs, especially in the posterior capsule. And the hyaloid phase, if at all that is intact, that also gets opacified. Hence, we do primary posterior capsular access in kids and anterior vitrectomy also. Okay, so despite of doing all this, sometimes we do see Elschnig pearls at the margins of the posterior capsule. At the margins of the posterior capsule, the lens epithelial cells migrate and there is Elschnig pearls noted. So this girl, basically, the reason why I've put is, she was a little less than 2-year-old when she had undergone the surgery. So we did the left eye surgery, she was fine. But by the time she came back for the other eye surgery, the lens had become very intumescent. And the minute we made a nick, there was an Argentinian flag sign. And we did remove the lens, implant an IOL, all that was done. But a few days later, those flaps which had separated, they kind of fibrosed and it came exactly bang in the center. So we had to go again, and since this was a very small child, so we could have not done any YAG or anything. So we had to take up this child for a membranectomy. Finally, she's doing well after, this is I think 2-3 years later after the surgery. So she is doing well, but there are chances of visual axis opacification after whatever best we do. So that has to be taken into account. That is the reason why we do PPC and anterior vitrectomy. In a smaller child, it is mandatory to do all this. And despite having done the best of the surgery, still there are kids who may develop secondary membranes. So that has to be removed in case if it is visually disabling. Here, can you all see the difference? What is the difference between these two prescriptions? This is the same child. Can you see this prescription and this prescription? This was written by a fellow, and later the child came to me. Parents came with a complaint that the child is not wearing glasses. The child is actually too delayed. The child has not even achieved neck holding yet. Actually, it is very difficult. Can you see? What is it? Spot the difference here. Can anybody comment? So here no sign was mentioned. Whether it is plus or minus, nothing was mentioned here. Okay. So the optician made minus 19.5 and minus 21 lenses. And when I saw the glasses, it was how it is like this. So that would probably, but the child didn't complain because the child was so delayed, he cannot complain anything. So finally we had to give. So we have to make sure that we put in a sign. I mean, this is something which I went and told the optician that this is wrong. So he's like, no, but you don't mention. So it can be minus, it can be plus, both ways. So this is in general, this is a lesson which I learned, that we should mention the sign properly so that the child, these are very expensive glasses, plus 20 and all are very, very expensive glasses. So that has to be made properly. So this is a child who had come from village. There is microcornea, if you can see. The child was neglected always, and that no treatment is possible. That is what was advised to the child. The child used to be always be accompanied by relatives and all. So there is microcornea. So do we put in an IOL? Do we not put in an IOL? Or we ask for a customized IOL? What would be the suggestion for this? The routine IOLs, will those fit in for a microphthalmos or microcornea eyes?
Customized IOL?
Customized IOL can be put. Actually, we as pediatric surgeons know we are not very fond of IOL. Somehow I feel we are happy with aphakic glasses because we don't know the follow-up of this child who is coming from a village. And also whether basically secondary glaucoma, the chances of secondary glaucoma are much more in eyes who are which are microphthalmic or who have microcornea. So we just gave left the child aphakic, and this was a very dense cataract. This was long-standing membranous kind of cataract. So having a good support and a multi-piece IOL in the sulcus, all that is very tricky. So we just left him aphakic. There is frontal bossing. I'm sure the child had many other anomalies too, but we just left him aphakic. So with respect to our patient, when we saw cataract in both the patients, why did we not do cataract surgery before? We all like to do cataracts, don't we? But we did not do the surgery. Why? What do you think? What is the deciding factor? The black reflex which we see on retinoscopy, that is the most important deciding factor. When there is a black reflex, when there is no glow, that is the time we advise surgery. Before that, if there is a good glow, if the child is able to see well, when the vision is good, we don't recommend surgery. What is the difference between lamellar and nuclear cataract? Nuclear is usually present since birth. I'm only answering everything. Anyways, nuclear is usually present since birth, and it usually involves the embryonic and the fetal nuclei, the central most part of the lens. And lamellar, it is more diffuse, and there are riders also which are seen, and it usually occurs later in life. It is not present since birth. It is usually a part of a developmental cataract. More community awareness is needed, I feel, especially with respect to consanguinity and vaccination for mothers for before planning any pregnancy for rubella. Thank you.
I think you definitely deserve a break because that was extensive. And do we have any questions from anyone? Yes, you can use the mic if anyone wants to ask. Instead of putting a message, you can directly ask. Ma'am is available. So I'll go ahead regarding this nuclear and lamellar. So is it going to make a difference in the prognosis? Do you feel? And presence of riders, is it a must for a lamellar cataract?
Not necessarily, not always you will have riders. Mainly it depends upon the zones up to which the opacification is present. If it is a little more extensive, that is lamellar. But practically it doesn't make any difference. It mainly depends on the glow and the vision. Associated nystagmus, squinting. Those are the usual signs based on which we would plan.
Generally, if we see in older child, we may call it a lamellar rather than a embryonic.
Usually they will come up with the history that the child was okay before and later it has come. And about 4-year-old, 5-year-old, 3-year-old, those are the ones who would come up with lamellar cataract. But nuclear would be usually present since birth. Usually that is non-progressive also, but sometimes it can opacify further.
And would the size be different between a lamellar and a nuclear?
Nuclear will be smaller. Lamellar will be more diffuse. Lamellar would be about 5-6 mm. Nuclear would be about 2-3 mm or so, 3 mm or so.
Because we had a case and there was a little argument by the members that some thought it was a nuclear cataract and some, though it didn't have riders. So I thought we'll clear it from who is expert in the field. So other thing is when we see a developmental cataract or in a patient who is more than 8 years or 10 years old, is there any role of investigating for the cause if there is
necessary? Not necessary. Mainly we investigate to find out any associated anomalies, especially intrauterine infections and all. So is there any associated rubella? If there is rubella, then we have to do a thorough 2D echo. I mean, we should make sure that whether there is any hearing disability. So those are the triad of congenital rubella. So those basically when we see a child, we are just not looking at the eye. We are treating the child as a whole. So mainly we have to see if there is anything associated with it. So those are the things which we need to address. If we see an 8-year-old or 10-year-old, it is not necessary to investigate. Only in cases of congenital cataract we investigate.
And do you see that there is increased risk of inflammation if they would be associated with these infections, or in the post-op, does the management differ even if the child is fine, but there is a antibody test which is positive and no?
Not really. Not really. Not really. Traumatic cases are the ones who throw up a lot of inflammation, but otherwise these kids don't. maybe our dose of steroid is much more. Maybe that is also a reason we don't see so much inflammation. Traumatic is something. Baki rest.
Yeah, that was the next question. What antibiotics or steroids do you prefer, and which do you
Prednisolone.
avoid?
Prednisolone acetate. It's better to go
Anything
ahead
which
with that.
you feel should be avoided or should not be used in
Combination therapy is not like monodexa or whatever gentamicin, I mean dexamethasone and moxifloxacin, though that is very commonly available,
right?
but that should not be mainly to avoid antibiotic resistance. But
Right. And do you give the anti-glaucoma medications or NSAIDs after these?
No, we don't give. We give steroid, we give antibiotic for a week, and we give cycloplegics just to keep that pupil in a mobile state, so that, and also to avoid inflammation. So basically, we are taking care of inflammation so much. Probably that is the reason we don't see so much inflammation.
Right.
Any IV steroids do you give post-operative?
No. Very rarely we give oral steroids. IV we don't.
Okay.
IV is not needed. Oral is more than enough, I feel. And there are reports of kids who have developed steroid-induced side effect. They have become like Cushingoid features have developed in kids with excess steroid. We have few patients. So actually the consensus is to go down on the dose of steroid, which we normally give in India. We probably give a much more higher dose. If we look at IITS and all, they give much lesser dose of steroid as compared to what we give in India. So we give about 10 times or so. IITS recommends about 6. So it is much more. So no, IV steroid is definitely not necessary.
Okay.
And regarding your choice of IOL, especially in developmental cataract, those who are above 8 years, is there a particular choice, or do you prefer any?
Acris or Falcon is what I've been using. No particular interest, but I mean no financial interest, but those are the lenses which have been, they are time tested. They have been here for many years, and
So you could describe whether it's a hydrophobic or a single piece or a multi-piece.
Single piece always in the bag. Single piece. If we have to put it in sulcus, then it has to be multi-piece, 3-piece. So it doesn't matter. It can be any of these lenses, but yes, for the bag, it has always to be single piece.
And what about using a multifocal or a
No. We are not very, I mean, there are some studies which describe multifocal and EDOF lenses, but in kids, these glare and the contrast sensitivity also kind of gets affected. And when we know that the refraction is not stable, such IOLs are usually not preferred, maybe, but for very old kids, who are probably more than 15 or so, maybe we can use, but we don't use it. I mean, all pediatric ophthalmologists will just raise an eyebrow and kind of, they will prefer not going for those lenses. So let those be used for adults alone.
Anuj, can I pitch in?
Yes, ma'am. Yes, ma'am. So we have Dr. Vaishali Une, who's a famous pediatric ophthalmologist.
No, not famous,
Hello,
but hello, yeah, a
Hello,
wonderful question. Just about the lenses you mentioned, so I couldn't stop myself. It's like hydrophobic square edge IOLs, because what I have seen is the posterior capsular opacification, VAO, visual axis opacification, is quite a headache for us. So that is very important. And I may have missed out. I'm sorry, I didn't. But suturing of the wound is also mandatory. So if the residents remember the things, that you have to suture the wound because of the scleral flexibility. So these two just points I wanted to mention. Great going. Thank you.
Thank you, ma'am. Thank you for the input, ma'am. Anyone else? Any doubts or any questions?
Ma'am, post-operatively, when you find the refractive error, when you do a retinoscopy, if it is more than what is expected, will you be adjusting it for the other eye, or will you go ahead with the primary value that we had taken according to the axis length with the undercorrection? And how much is the expected refractive error that we can keep between both the two eyes?
So we have to take that into account. We before planning the other eye surgery, we have to do the first eye's refraction, and then only we can post for the other eye. If it is acceptable, I mean, if it is not going to cause too much of anisometropia, then we can probably go ahead with whatever we had planned. Or see, if it is a little more on the hyperopic side, say we were targeting +3 and the refraction has come about say +5 or so. Now this would be my personal take on this. Maybe the other eye we can target +4 or so, but I mean, we cannot like totally how do I put it? Like we cannot totally change, and if the child is say 3-year-old and if we are getting say +5, we are okay. So maybe we can target the other eye also at +4 or +5, because by age 7 or 8, the child is probably going to attain emetropia. So that is acceptable. If it is say +3 is what we target, and if we get say +4 or +5, that is acceptable. That is okay. But if it is grossly different, then I don't know. I mean, actually, I don't know. I've not encountered this too much of a surprise, so don't know how to tackle it. But yes, I mean, I've not even seen that if bahut sara surprise aa gaya, so we have to go ahead and change IOL exchange. All that is technically very difficult because we have put in an IOL in the bag. To remove it out and mess up all that, no, that is not okay. जब तक myopic surprise नहीं है, I'm okay.
Okay.
जब तक थोड़ा hyperopic है, तो it's okay. We can probably, but yeah, we cannot leave a lot of anisometropia. So we may have to balance out between the two. That is there.
Okay. Thank you.
And any time do you feel that the refractive error is also, does it influence your indication for surgery?
Refractive error. No, like rather this case we were so I'm still little, see, this child has not undergone surgery yet. I'm
Right.
still in a dilemma because -18 वगैरह है. I don't know इसका biometry होगा तो it would come down to plano or something, and the sibling has developed retinal detachment. We are very scared actually to do surgery because, but the glow is very poor. We barely can see anything, so there is no other choice left but to do. No, refractive error doesn't matter whether, if the vision is poor, I mean, if the glow is dull, that is the most important deciding factor for us to undergo planned surgery. So it is not on the refraction. We are not doing surgery to just bring down the number of glasses. No, we are not doing with that. We are anyways going to give them glasses. They have to wear glasses all their life, so it doesn't matter what is the number. It is just a number. Child has to have good vision. That's it.
Regarding glaucoma, how often do you check for IOP, and what is
At every visit, we should check for IOP. At every visit, we check. We feel that the child may not cooperate. Most of the kids cooperate for applanation also. But if they do not, then we kind of sedate them. Or when they are physiologically in their sleep, we put Paracane and check with either with Tonopen or Perkins or eye care, whatever. Eye care is good, I feel, because it is practically kind of non-contact kind of, but the child has to cooperate. But we need to check the IOP. Yes. We used to give pedichloral syrup in OPDs and sedate the babies and then check for IOP. So a lot of time myopic shift also is seen in kids with glaucoma. So that also aids us as an aid. I mean, it tells us that the IOP is probably, and of course we look at the disc also when we do dilated examination. So before the dilatation, if the child is awake, it is good for us. After dilatation, if the child goes off to sleep, we can check in the fundus and IOP and everything. So anyways, the child doesn't, these small babies don't stay awake for long. So that way also it can be worked out.
and any role of low dose atropine which we use for preventing progression in
Low dose atropine works equally well. So probably it is acting on the sclera. That is probably the role, because we used to think that it works on the lens, but there are various theories. So I feel low dose atropine is working because by acting on the sclera per se in these pseudophakic patients. So it works. It is giving good results. If there is a lot of myopic progression, low dose atropine can also be prescribed, like how we do it in all other children.
So in these cases where you have prescribed dilating mydriatic drops, do you want cycloplegia as well, or just for cataract?
No, we can just put Tropica cell and can
So
dilate
then
them.
how
So
often do you dose, and do you give any break period for the dilatation? Is there any like a drug off day, and till how long do you continue this treatment?
cycloplegia, that is just, I mean, post-op, that is just for a month.
No,
That's it.
for a visually significant cataract which does not require a surgery.
Those kids, like this baby, no, the girl whom we saw, until the child is able to comprehend for vision assessment.
Okay.
So this child was 1 month old when the child had come. And at 2 years, these days kids start speaking at 2 years of age. They know all the alphabets. So I think once the child is vocal, once we can assess vision, we cannot, I mean, subjectively the child has to cooperate. Of course, we have our own methods of evaluation whether the vision is good. But until the child speaks, we have to keep them on dilating drops. Yes.
So this is every day the drops are put, or
Yeah, every day, twice a day at least. So we had a child who's older, pretty older, I think 15, 16 or so. She has posterior subcapsular opacification, posterior subcapsular cataract, but it is partly obscuring the visual axis. Whenever we put her on tropicamide, the vision is little better. When we stop it, it kind of still drops. But now the child is 15, 16 or so. She has 7.5 or so vision in one eye, and the other eye is 6.6. So we've just left it at what? I mean, we have not operated her, but she's okay. And 7.5 is acceptable. With the other eye having good vision, I think it is okay to just leave her like that. So she's doing well. Last week only I saw her. So she's okay.
any other questions? Anyone or any inputs which we can discuss, or
One last question.
yeah, go ahead.
In bilateral cataract, after one eye is operated, how soon should we operate the other eye so that dense amblyopia doesn't set in?
A week or 2 weeks max. Usually
Okay.
we operate in a week's time. We used to do bilateral surgery also, which we don't do usually in India. We used to do bilateral surgeries. It has been described in literature. Simultaneous cataract surgery for neonates, basically infants, for congenital cataract. Like how ROP surgeries have also been described. Basically, it is to avoid anesthesia risk. But there are chances of endophthalmitis, and if at all it occurs, God forbids, it may happen in both the eyes. So we don't want that. So usually a week's interval is good. And we used to like redrape the patient and do one eye, then scrub again, take a different nurse. We had a different trolley, different irrigation fluids, everything. I mean, it was totally treated as two eyes separate. But so that used to be done, but no, we don't do it anymore. We just treat it as at an interval of 1 week.
Okay. Thank you.
May I? Anuj, may I?
Yes, ma'am.
Yeah. I have an experience of almost 12 cataracts, which I have done sequentially bilateral cataracts. So usually I do it when, especially working in a government hospitals, the rate of follow-up is very poor, and when there is anesthetic problem also. So in one go itself, so luckily for me, none of them had any untoward incident. So if proper precautions, and like you have already said, that we treat the other as a totally new surgery, so new scrubs, new everything is new. So it is good when you have to, but balance what like whether doing it in the same setting, sequential, bilateral. But with my 12 cases, it has been quite good for me.
We actually had a study on this. We did some, I think 50, 60 eyes or 120 eyes. I don't remember. I think it was 50, 60 patients and 120 eyes. We had a huge study, and all of them were good. But then we had one episode of end-off in one eye. So that is when we stopped it. So I mean, I will not say that this is the way to go. It is okay probably, but yes, anesthesia risk are much higher.
Yeah.
We have a standby pediatrician, we have an anesthetic. Still, it is very difficult, and these babies are usually very precious. So parents are also very scared to undergo the anesthesia procedure again. So it is risky, but yes.
Yeah. The main is the risk of anesthesia. That's why, and also the parents coming for the second surgery and then the follow-up. So all that we have to weigh and see what is good for the patient finally.
Yeah, I understand, ma'am. In a government setup, as you said, logistics is also to get a pediatric anesthesia twice, it would take even months, even if the patient is there. But how the the logistic issue is really an issue. And
And the investigations also, again, the child has to undergo all those investigations, then getting the fitness, and also I have done that quite frequently, I should say. But yes, that risk hangs very high of endophthalmitis, so it's double-edged sword. But every case has to be weighed properly and then decided on.
what about these drops to dissolve cataract, which some of them believe in adult cataracts, like potassium iodide and all these combination? Do you prefer in pediatric age group? Or do you feel they don't work, or do you feel that they should not be given?
I don't know. I have not tried any of these. I have not tried any of these. I don't.
Right.
So here the mechanism is only different. No, I wonder how will the drops work. I don't know.
Yes, till now we used to feel that no drops will work, but of late we have been coming even in evidence-based medicine, a lot of drops which are supposedly working, though they have not been FDA approved till yet. But
I'm not aware of these drops. We have never tried, so I don't know.
because a lot of people believe for even for cortex and this they use drops like Catsol or Catnil, which they use for adults. So any experience even for
No,
PC
no,
or
no, no.
anyone any questions so that we can relieve Dr. Khyati? I think we'll call it a day. And
Thank you.
it was really nice that, and it was extensive, and it was great to have good participation from Dr. Une ma'am, and we have Dr. Shubha Zawar ma'am also who had attended. And so we really got some good inputs, and I think this will really help everyone in managing these cases better. And thanks for taking out the time, and we'll see you again.
Thank you, Dr. Anuj, for this opportunity. Interacting with postgraduates is good. Thank you.
Okay, thank you.